Welcome everyone to the Health Economics Alongside Trial Special Interest Group webinar treatment switching on trials and integration into economics practice. My name's Nhung Nghiêm. I'm a health economist and a modeler at Clinical Hub for Interventional Research at Australian National University in Canberra. I'm a co-chair of the HIT6. Please move on to the next slide. So I would like to start by acknowledging the traditional custodians of the lands on which we live, work, and meet today, and pay our respect to the either past, present, and emerging. We extend that respect to Aboriginal and Torres Strait Islander people here today. For housekeeping, please ensure that your microphone is on mute. Raise your hand to speak in a Q&A question. Please use the chat function for any question and we will attempt to answer all the questions during the Q&A question. A record of the webinar will be available to watch on the ICT website and the YouTube channel. So Natalia will send an email when it's become available. We would appreciate your completing a pre-post survey, webinar survey that will be sent out as well. Our speaker today, Nicola Latimer, is a professor of health economics at the University of Sheffield, UK, and an analyst for the Pretoria Evidence. He was a member of NICE Technology Appraisal Committee B for 5 years, has been an invited expert on NICE scientific advice programs, and is a member of the NICE Decision Support Unit. Nick research focused on survival analysis in economic evaluations. He has authored 5 DSU technical support documents related to survival analysis, treatment switchings, and partition survival model. So treatment switching is where patients recruited into a randomized controlled trials switch away from the treatment to which they was randomized. That is common in trials of oncology treatments. In HTAs, we need to estimate the clinical and cost effectiveness of inserting new treatments into the treatment pathway. If the treatment pathway followed in the RCT from which we are taking evidence does not reflect the treatment pathway that would be followed in clinical practice, so the standard intention to treat analysis will not provide the evidence we need to inform the HTA decision making. So instead, we need to estimate outcomes that would have been observed had relevant treatment pathway have been followed, which may involve needing to adjust for treatment switch that occur in the RCT. So in this talk, Nick will discuss when we may need to use method to adjust for treatment switching in oncology trials. So before I hand it over to Nick, I think that Nick would like to participant to save the question at the end of the presentation. But if you have burning question, Nick would mind to respond during the presentation. So now I hand it over to you, Nick, for the presentation. Thanks.
Okay, thanks very much. Thanks for the introduction. I will just share my slides. Okay, is that shared all right? Great, thank you. So thanks everyone for joining us. I know it's after 5 o'clock for quite a few of you, so thanks for hanging on. I'll try not to keep you too long. I'll go through my slides. So yes, we're talking about treatment switching in oncology trials and integration into economic modelling practices. So these are the areas that I'm going to cover today. A bit of background. I actually spend quite a bit of time on background when I do talks about treatment switching because I'm a methods person really and mainly interested in methods. But if you just start talking about the methods straight away, then you can forget about why you're actually using the methods. And what I've found in the past is that sometimes, quite often actually in this area, people start adjusting for treatment switching when they don't need to, or they don't adjust for treatment switching when they do need to, and people adjust for the wrong things, and then you can use amazing methods, but if you use them to do the wrong things, it all becomes a little bit useless. So we need to try to avoid that. So first of all, a bit of background, then I will cover the methods, but only kind of quite briefly. Some of these methods are quite complicated and you can't really expect to explain them all in detail in this kind of session, but I'll give an introduction to them. Then talk a little bit about how we decide which of these methods we should use in different cases and how these methods are actually used in HTA before offering some conclusions, and we can then have a bit of a discussion. So the background part. So I always think it's quite helpful to start from the basics of what we're trying to do in economic evaluation. So and this is going to be obvious to everyone really, but I think it's useful to start here. So economic evaluation aims to ensure that the benefits of programs that are implemented exceed their opportunity costs. And so when we're doing this, the aim is to compare the new treatment to all relevant comparators. And when it comes down to it, what this usually involves is a comparison of the costs and the effects of the new treatment versus the standard treatment that's currently being used. And in a very kind of simplified way, this leads to the kind of decision problem that we usually face in HTA, which is something like this. So compare a state of the world where the new treatment exists to a state of the world where the new treatment does not exist. And that's essentially what we're trying to do in the economic model. And usually when we're making these comparisons, we take information from randomized controlled trials. That's the kind of gold standard evidence where we hopefully get unbiased evidence of treatment effects. And we take intention to treat analysis treatment effects from these randomized controlled trials because that avoids lots of biases. But in this context of treatment switching, what if patients randomized to the control group in a clinical trial are allowed to switch on to the experimental treatment at some point during the trial? So if we have that kind of treatment switching, then we lose the kind of nice clean comparison of state of the world that we would like to have to address our decision problem, because then people in both arms of the trial end up receiving the new treatment. We no longer have this state of the world where the new treatment exists and the state of the world where the treatment doesn't exist. So if we have this kind of treatment switching, we may lose the ability with an intention to treat analysis to really address the decision problem that we have. And you can show this on a diagram. Most of my work is in cancer. So when I'm explaining this, I'll often use cancer examples. And here we've got overall survival made up of progression-free survival and post-progression survival, which anyone working in cancer will recognize as key elements of an economic model in this area. So we might often have a control treatment that has progression-free survival, post-progression survival, taking you up to your overall survival time. What we would like to see is a new intervention that extends both of those things. So it extends PFS, it extends post-progression survival, and we get this nice big overall survival advantage associated with the new intervention. And essentially here we have the state of the world without the new intervention, state of the world with the new intervention, and we know the difference between them. That's what we want to know for the HTA. However, quite often in cancer trials, treatment switching is allowed. And when treatment switching happens in cancer trials, it's usually allowed to happen at the point or shortly after disease progression. And that's because PFS is often the primary outcome in oncology trials. And once we have evidence on PFS, there's less kind of motivation to retain the differences between the treatment groups in terms of the treatment that they're allowed. And also for ethical reasons, if it looks like the new treatment might be good, then quite often the people who were randomized to the control group are allowed to switch on to the new treatment. So usually that happens after disease progression has been observed. So imagine that case. PFS isn't altered in the control group because usually switching is only allowed after disease progression. But post-progression survival in the control group may be longer than it would have been if treatment switching hadn't happened. And that recognises the fact that the people who switch onto the new treatment may benefit from it. And so their post-progression survival might be longer than it would have been if they hadn't been allowed to switch. So then if we do an intention to treat analysis that just compares the randomized groups, we now see this smaller overall survival difference between the intervention group and the control group, because some of the control group patients have switched and done better than they would have done if they hadn't switched. So fundamentally, all of the methods that I'll talk about try to take us from what is observed according to the ITT analysis in the clinical trial to what we really want to know for HTA. So they try to estimate what would have happened in the control group if the switching hadn't been allowed. So this kind of treatment switching does happen often in cancer trials. When I first started looking at this area, it seemed a little bit strange that you would have randomized control trials that would allow treatment switching. You might think, well, why would you go to the trouble of running a randomized control trial but then allow people in the control group to receive the new intervention? And there are lots of arguments around that, and you could spend a long time debating whether treatment switching should be allowed in trials or not. But the fact is that it does happen a lot, and I did a review, this is quite old now, but I think it's still true now, is that over half of the technology appraisals of cancer treatments that NICE have done in the UK have been affected by treatment switching. And when you consider that in the UK anyway, and I think this is probably similar in Australia too, it's something like half of the HTAs that NICE does are in cancer. So half of them are in cancer, and then half of those are affected by switching. It's quite a large proportion of the total number of technology appraisals that NICE does are affected by this problem. So it's a common problem, and also it can have a really big impact on estimates of effectiveness and cost effectiveness. And this is just one of the, I guess it's quite a well-known example of this situation. And it's also, I think, the first time a kind of complex advanced method was used to adjust for treatment switching in a NICE appraisal, was this example of technology appraisal 179 of sunitinib for gastrointestinal stromal tumours, which was done way back in 2009. So in that technology appraisal, 84% of people who were randomised to the control group ended up receiving sunitinib, so a really large proportion of treatment switching. So I'll give you a bit of an overview of what happened there. So it was in RCT, 2-to-1 randomisation, so 243 people in the sunitinib group, 118 in the placebo group. The trial had an interim analysis built into it, and at that point there was a maximum follow-up time of 54 weeks. And when they did that analysis, the hazard ratio for overall survival was 0.49, so sunitinib looked really good. Based on that, the data monitoring board on the trial recommended that people who had been randomised to placebo should be allowed to switch on to sunitinib. And after that point, that's when the 84% of patients in the control group did indeed switch on to sunitinib. Then at a later follow-up, when they did the analysis again, using an intention to treat analysis, the overall survival hazard ratio now was 0.88. And this was the data cut that was used in the NICE appraisal. And the incremental cost effectiveness ratio associated with that survival data was £77,000 per QALY gained. So usually NICE is willing to accept things that have an ISA of 20 to £30,000 per QALY gained at this time. That has changed slightly recently. But you can see that that ISA is too high. And based on that ISA, NICE would not have recommended sunitinib. But the company and the evidence review group and the appraisal committee recognised that the treatment switching was important. And this was I said this was the first time a complex advanced method was used in a NICE appraisal to adjust for treatment switching. And the method that they used was the rank preserving structural failure time model, RPSFTM. And when they applied that method, they estimated a hazard ratio of 0.51. So they estimate that if the switching hadn't been allowed, the hazard ratio would have been 0.51, which is like almost the same as the hazard ratio that was seen at that interim analysis. And the incremental cost effectiveness ratio associated with that hazard ratio was £32,000 per quality gain. So the ISA more than halved and came very close to that threshold that NICE uses. And in fact, based on that, the committee accepted that adjustment analysis, and sunitinib was recommended for use in the NHS. See, this is just an example to show that in this case, if this adjustment method hadn't been used, probably sunitinib wouldn't have been recommended for use in the NHS. So this analysis may well have been what was a key driver in getting this drug actually recommended. So that's why it's important, and it's important for us to kind of consider this switching. It's also true, though, that not only can adjusting for switching or not adjusting for switching have a big impact on the results, the actual method that we use to adjust for switching can also have a big impact on the results. So this is another quite old example now, but it highlights the issues quite nicely. So this was NICE Technology Appraisal 215, pazopanib for renal cell carcinoma. So in this example, 51% of patients in the control group switched on to pazopanib during the trial. And in this appraisal, the company presented lots of different analyses that adjusted for switching in some way. So first of all, starting with the intention to treat analysis that doesn't make any adjustments, the hazard ratio for overall survival versus interferon was 1.26. So it's actually greater than 1. So it looked like pazopanib was actually worse than interferon, and that led to the ISA being dominated. So it led to pazopanib being dominated. It was both more expensive and seemingly less effective than interferon. So definitely wouldn't get recommended. But then they did lots of other analyses. So they did analyses where they simply censored patients who switched at the time that they switched. They did analysis that completely excluded patients who switched. And just those two analyses, you can see the hazard ratio for the censoring approach was 0.8. For the exclusion approach was 0.48, with like wildly differing ISAs as well. Those kind of methods were actually used very commonly early on, before kind of, I don't know, probably before 2009, I suppose, when the sunitinib example, but also it continued after that for some period of time. These censoring and exclusion approaches were the most common things done to deal with treatment switching in NICE appraisals. But if you think about those methods, they're quite bad, basically. They're very prone to selection bias, because if you imagine you're a clinician working on a trial where treatment switching is allowed, and a patient comes for a consultation, and you can see that their disease has progressed and they were on the control treatment, you're allowed to let them switch onto the new intervention, then your decision as to whether to recommend that they switch treatments is not just going to be random. It's going to be based on their prognostic characteristics. Are they likely to be able to tolerate this new treatment? Are they likely to benefit from it? And so if we then just exclude patients who switch or censor patients who switch, we're very likely to bring in selection bias to the analysis. So those two methods we kind of want to ignore. We think they're very, very prone to bias. But in this pazopanib appraisal, the company also presented these two other more advanced methods. So inverse probability of censoring weights, IPCW, and rank preserving structural failure time model again. And you can see with those two methods, IPCW gave a hazard ratio of 0.8, RPSFTM a hazard ratio of 0.63, and the ISA varying from just under £40,000 per quality gained to around £72,000 per quality gained. So you could kind of imagine a case, especially in the context of the end of life decision-making rule that NICE had, where you could sort of basically accept an ISA up to about £50,000 per QALY gained, then if you believe the RPS-FTM, you might recommend pazopanib. But if you preferred the IPCW, you probably wouldn't recommend pazopanib. So this kind of shows that even the method you use to adjust for treatment switching could change the decision that you make. So that's why it's really important to understand the methods here, so that we can, why do they give different results? Which method is likely to be most appropriate on a case-by-case basis? In this case, the committee preferred the RPS-FTM, and pazopanib was recommended. And it's not just these two methods as well as the IPCW and RPS-FTM. Another method, two-stage estimation, has been used in HTA to adjust for treatment switching. And so, as I said, we need to understand these methods, the differences between them, so that we can understand which one is likely to be most reliable on a case-by-case basis. Okay. So I am going to explain those methods in a bit more detail, but first of all, I just want to spend a bit of time talking about the different types of treatment switching and what we actually want to adjust for. So you can kind of quite simply divide the different types of switching into three different types. So the first one is just switching from the control treatment onto the experimental treatment. And those are that's the example that I was giving in the sunitinib and pazopanib examples. It was where people who were randomized to the control treatment switched onto the experimental treatment during the trial. So that's a really common type of switching that happens in cancer trials. And you can refer to that as direct switching because it's switching directly between randomized groups for randomized treatments. Second type is switching from experimental onto the control treatment. And it's just direct switching again, but in the opposite direction. So you can have that. People who are randomized to the experimental group may, after their disease has progressed, or if the experimental treatment they can't tolerate, may switch on to whatever was being used in the control group. And then thirdly, you could have switching from either the control or the experimental groups onto some other treatment. And that's often referred to as indirect switching because it's not switching directly between randomized treatments, it's switching onto something else. So let's think about which of these types of switching we would want to adjust for. So if we think about direct switching first, so switching from the control group onto the new treatment. If the new treatment is completely new, it's not been used before, it's new to the health system, then switching from the control treatment onto the new treatment doesn't represent a realistic treatment pathway that could happen. The new treatment isn't available anywhere else in the treatment pathway. So if that happens in our trial, then we probably want to adjust for this. Sometimes the new treatment is already available at the next line of therapy. So for example, you do get, again, in the context of cancer, but it'll be true in other disease areas as well. Sometimes you get, well, often you get new treatments that originally are tested at late stages of care, where the need is the highest. And then if the treatment is good there and it works there, then the company might start doing trials at an earlier line of therapy and bring it forward in the treatment pathway. So then in that case, say we're doing a nice appraisal or an NEHTA appraisal of this treatment at first line of therapy, but it's already available at second line, then our kind of relevant treatment pathway in the control group would be whatever is standard of care at first line, followed by this treatment at second line. That's because that's what's currently happening in the health system. So then if we have patients in the control group in the trial switching onto the new treatment at second line, that just reflects what happens in the health system, and we don't need to adjust for that because that is what happens in standard therapy at the moment. So sometimes we can have switching, this direct switching from control onto experimental treatment, and we may not need to adjust for it. It depends if that treatment is already available at the next line of therapy. Switching from the new treatment onto the control treatment. Quite often in trials, the control treatment does represent the standard therapy, and therefore it is quite likely to form part of the standard treatment pathway. So if we have this switching from the new treatment to the control treatment, which could be due to a lack of efficacy or toxicity or something, then again, that may represent a realistic treatment pathway. And so usually in this case, we don't need to adjust for that type of switching. It's just something that would happen in reality as well. And so we don't need to adjust for it. And then thinking about indirect switching. So often in trials, almost always in any trial, in any disease area, there's a range of treatments available. And so if one treatment stops working for a patient, they're very likely to switch on to another treatment. And so it's very common in trials for patients in both randomized groups to switch on to some other subsequent therapy. And whether or not we want to adjust for those switches all depends on whether they represent part of the standard treatment pathway or not. If those treatments that people switch onto are available in the real world, it's what would happen in the real world. It represents a realistic treatment pathway, and we don't need to adjust for that. In fact, we don't want to adjust for it because it does represent what would happen in reality. If the treatments that people are switching onto are not standard treatments, they're not available in the real world, then those switches represent an unrealistic treatment pathway. And so it is necessary and it is desirable to adjust for those switches. So just summarizing that, the switching from control onto experimental group, almost always we do want to adjust for that, but not if the experimental treatment is already available at the next line. Switching from the experimental onto the control, usually we don't need to adjust for that because the control treatment is usually a standard treatment that is part of the standard treatment pathway. And switching from the control or experimental group onto other treatments, whether or not we want to adjust for that depends on whether those treatments that people are switching to form part of the standard treatment pathway. So what we should adjust for depends on our decision problem, what we're trying to compare, and whether treatments patients switch onto are available in standard clinical practice. So that's the kind of introduction to what we want to adjust for. If you do have any questions about that, then I'm happy to talk more about that at the end. So now I'll do a kind of brief introduction to the adjustment methods. So say we've decided we do want to adjust for something, how do we do that adjustment? So broadly, if we've decided we do want to adjust for something, we have three key options. So we could just exclude people who switched or censor them. But I've already explained that that's going to be usually a bad thing to do because it's going to result in selection bias. But we can elaborate the censoring approach using weights to try to get rid of the selection bias. And that's essentially what the inverse probability of censoring weights method does, IPCW. I'll talk about each of these methods in a little bit more detail after this slide. The second option is that we can model the treatment effect after switching. So we can try to estimate the effect that people that switch receive. And if we can estimate that effect, we can use it to derive what would have happened to those patients if they hadn't switched. And that's essentially what the two-stage estimation method does. And the third option is we can just model the treatment effect in general in the trial. So not distinguishing between the effect received by the experimental group and the effect received by switchers. And that might sound a little bit strange, but I'll explain that in more detail in a few minutes' time. And that's what the rank preserving structural failure time model does. So those are our three key options. So first of all, the inverse probability of censoring weights method. So I think it's easiest to think of this as an extension to the simple censoring analysis, and it can describe it with 4 steps. And the first step is that simply we censor switches at the point that they switch treatments. But then we kind of acknowledge that that censoring can lead to selection bias. And so to try to get rid of that selection bias, we estimate weights. And we do that by first modeling the probability of switching. So that can be according to baseline and time-dependent characteristics, can be things like ECOG performance status, health-related quality of life scores, lesion size, any kind of prognostic covariate that we think might be we can include in this model for the probability of switching. We then use these probabilities to compute weights, and the idea behind this is that we find people who didn't switch but had characteristics that are similar to patients who did switch, and then we upweight those people. And the weight equals the inverse probability of not switching. And I always used to find that a really confusing kind of sentence or concept, the inverse probability of not switching. But it's not actually that difficult. If you imagine the case where you fit this model for the probability of switching, and you find a patient who at a particular time point had a probability of switching of 0.8. So they were really likely to switch, but they didn't switch. Then that means that the probability of not switching for that patient is 0.2. And the inverse probability of not switching is 1 over 0.2, so it's 5. So that person who had a probability of switching but didn't switch, their probability of switching was 0.8, then we end up giving them a weight of 5, recognizing the fact that they were really quite similar to switches, but that they themselves didn't switch, and so we upweight them. And what that means is that they account for themselves and they account for patients who were similar to them but switched and who have been censored from the analysis. That's what the weights are trying to do. Find people who were similar to the switches but didn't switch, and upweight them so that they kind of account for themselves and the people that we've censored due to switching. We then use those weights in our survival analysis to remove the selection bias associated with the censoring that we've enforced. And in context of economic evaluations, often we use parametric survival models to go into our economic model, and we can just fit those parametric models to the weighted data set to model survival. Although in this case, we'd probably want to do something like bootstrapping to account for uncertainty appropriately. So you'll notice throughout this presentation, I've got some slides with a red star on, like this one. That means that I'm not going to go through it in detail, but I thought it's helpful to put these slides in the deck, just so that when you've got more time on your own afterwards, you can have a look through these slides. This series of slides is just explaining how that weighting concept works over time. But I'll leave you to look at that in your own time. So some key points associated with IPCW. An advantage is that it can adjust for any type of switching in either treatment arm. So it could be direct switching, it could be indirect switching, it could be in a control group, it could be an experimental group. Any of that is fine. We just censor the patients who switched, and then we use the weighting models to deal with the selection bias. A key thing is that we need to be able to upweight the right patients. So as I said, the key to this is we find people who didn't switch, who had prognostic characteristics that were similar to people who did switch. But obviously that means we need good enough information so that we can identify which patients who didn't switch were similar to the patients who did switch. And that assumption is often referred to as the no unmeasured confounding assumption. So essentially means that we need data, we need covariates measured on everything that causes switching, influences switching, and also is prognostic for survival. Those are the confounding variables. And those are the ones that we need to include in these weighting models. Selecting which variables to include in our weighting models is actually really important, and clinical expert opinion is going to be important there. We don't want to base it on statistical significance in a regression model because these trials aren't powered to find prognostic factors. And quite often it's going to be important to do sensitivity analysis testing different model specifications. One thing just to highlight is that in my experience, NICE committees and external assessment groups often think that when we're using this kind of method that relies on no unmeasured confounding, we need to include everything that might be important in this model. So we just put loads and loads of variables into these weighting models. But that can actually be problematic because sometimes there are some variables that if we include them, it can cause more bias, and those are called collider variables, and I won't say more about them now. This all comes down to causal inference methods, and things like directed acyclic graphs can be helpful for selecting variables in these contexts. But just to be aware that this no unmeasured confounding assumption doesn't mean we should just chuck everything into the model. That can actually be a bad thing to do. And also including unnecessary variables can just make the weights that we estimate really high. Some patients can get extremely high weights, and then the method becomes prone to large errors. So we need to be really careful with covariate selection. What you will often find with this IPCW method as well is that you can get big problems if you have really high weights. Some people get extreme weights, and that happens more regularly if you have a small sample size and a large switching proportion. Imagine a trial that only had, say, 100 patients in the control group, and say 80% of those patients switched. That means you only have 20 patients left in the control group who didn't switch, and it's those 20 patients that you end up upweighting. So the smaller and smaller that number gets, the smaller number of patients that you're using to try to represent the whole control group, and that's where the method becomes quite prone to error and bias sometimes. Also, in a trial context, data collection over time can be a problem. We need these variables measured over time during the trial, and so if that's not there, if for whatever reason some variables data wasn't collected on for the duration of the trial, then this method can run into problems. Okay, second method, two-stage estimation. So this method was actually designed specifically for a case where switching happens after a specific disease-related time point, such as disease progression. We then use that time point as a secondary baseline and analyze the data beyond that as if it was an observational study. And this is the one where the idea is that we estimate the treatment effect associated with switching, and that allows us to derive what would have happened to those control group patients in the absence of switching. And there are 4 key steps associated with this method too. So in this diagram, imagine here we're just looking at control group patients. So we're just looking at a case where there's switching in the control group that we want to adjust for. So we have control group non-switchers at the top, progression-free survival, PFS, and post-progression survival, PPS, and then survival in switchers at the bottom. So again, they're PFS and PPS. And you can see, the way I've drawn it here, people who switched had a longer PPS. I've drawn the PFS times to be similar. That doesn't have to be the case. It's just for ease of illustration. So the first step with the two-stage method is to identify this secondary baseline secondary baseline time point in the control group. And so in this case, I'm saying switching is only allowed after disease progression. So we use disease progression as a secondary baseline time point. We then compare post-progression survival, post-secondary baseline survival in the 2 groups, switchers versus non-switchers, and estimate a time ratio associated with switching. So we use an accelerated failure time model to do this because we want to estimate a time ratio rather than something like a hazard ratio, which is what you get from a proportional hazards model. So we use an accelerated failure time model because that gives us a time ratio. And in this model, we control for prognostic variables measured at the time of the secondary baseline to try to isolate the effect of switching. Once we've estimated that time ratio, we can simply use it to kind of shrink survival times in switches to derive counterfactual survival times, the survival times that they would have had if they hadn't switched. And then we've essentially got a new data set with adjusted survival times for switches. And again, in an economic modelling context, we can fit parametric survival models to this adjusted data set. But again, to account for uncertainty and the fact that this is adjusted data rather than observed data, we would actually need to bootstrap the whole process to characterize uncertainty properly. Some key points with the two-stage method, like IPCW, it can adjust for any type of switching in either treatment arm. A secondary baseline must exist, so switching only after a disease-related time point. Similar to IPCW, it's reliant on this no unmeasured confounding assumption. We need to be able to adjust for prognostic differences between switches and non-switches so that we isolate the treatment effect of switching accurately. And again, the selection of variables is important to do that. And again, using sensitivity analysis, looking at different model types and specifications is important. Another point to make about the simple two-stage method is that ideally we need switching to happen either immediately upon disease progression or soon after disease progression, because we adjust for covariate differences between switches and non-switches measured at that secondary baseline time point. But if switching is actually happening sometime after that point, then the method becomes prone to time-dependent confounding. And that's because this simple version of the two-stage method uses simple regression techniques that can't deal with time-dependent confounding. However, more recently, a more complex version of the two-stage method has been developed that uses G-estimation instead of simple regression, and that can deal with this problem. Again, I won't go into more detail about that now, just to make you aware. Okay, final method. So rank preserving structural failure time models, RPS-FTM. So like the two-stage method, this estimates a treatment effect associated with switching, which then allows us to derive what would have happened in the absence of switching. But the key difference is that it doesn't distinguish between the treatment effect in switches and the treatment effect in the experimental group. It assumes that there's a common treatment effect. So the treatment effect is the same in switches as it was in the experimental group. That might seem like quite a limiting assumption, but it's also got important advantages. Basically, this means that we don't need to make the no unmeasured confounding assumption. I won't go through the details of the RPS-FTM and how it works because it'd take a little bit too much time. Basically, it makes this common treatment effect assumption and uses the magic of G-estimation, which if people do want me to explain it afterwards, I could do, to estimate this common treatment effect. And then once that common treatment effect has been estimated, we're able to estimate this counterfactual data set in the same way that we did for the two-stage method. There's a few limiting things with the RPS-FTM. It means that we can only adjust for switches between randomized treatments because we're assuming that the treatment effect in switches is the same as it was in the experimental group. Really, we can only deal with cases where people are switching between randomized treatments, which is more limiting than the IPCW and the two-stage method because, as I said, they can adjust for anything. This common treatment effect assumption is often seen as a big disadvantage because you might think, well, it's quite unlikely to be the case that somebody who switches later on in a trial is going to get the same treatment effect as somebody who was originally randomized to the experimental group. But we can do sensitivity analysis around that, and I would say we always should do, to see, okay, what would happen if people who switched got a 10% less treatment effect, 20% less, for example. And I think that kind of thing is rarely done, but it always should be. The important advantage of this method is that it doesn't need the no unmeasured confounding assumption. So we don't need to measure a load of covariates throughout the trial. We don't need to decide which of those to include in a model. And that's a big advantage over IPCW in two-stage. That also makes it less sensitive to switching proportions and sample sizes. It can work well even with really high switching proportions and quite small sample sizes. And we should also, like any of the methods, do sensitivity analysis, testing different ways of applying the method to see how robust the results are. Okay, I'm aware I don't have long, so I'm going to breeze through some of these things and try to pick out the most important bits. When we're identifying appropriate methods, it's difficult to choose which ones to use on a case-by-case basis. We saw with the pazopanib example, different methods can give different results. So we need to think about the methodological assumptions that the methods make. Are they plausible? We need to think about practical issues. How's the method been applied? If we test different model specifications or different ways of applying the method, do they give different results? We can also look at the evidence on performance of the methods. So quite a lot of my work has been simulation studies on these methods to see how well they work in different scenarios. And again, these are starred slides, so I won't go through them, but they just give you a little bit of information about how well these methods do in different scenarios. What you can basically take from these simulation studies is that methods like RPS-FTM work well when there isn't common treatment effect. But obviously, when there isn't a common treatment effect, the method becomes prone to bias. IPCW in the two-stage method can become quite volatile if you have small data sets and large switching proportions. But if you have larger data sets and you have good data collection, these methods can work quite well, even in quite complex scenarios. Overall, it's basically very important to assess the trial data and assess whether the assumptions made by the methods are likely to be appropriate, and that can help us determine which method is going to be best on a case-by-case basis. What we definitely shouldn't do is just pick one, and this often is done in HTA. I've found that somebody will say, well, in technology appraisal X, RPS-FTM was used and it was accepted, so therefore I've used it here again. But different methods can work well in some cases and not well in other cases. So we shouldn't just use prior experience. HTA agencies have seen these methods quite a lot. In my experience, I think NICE and PBAC are quite open to these methods. Some other agencies aren't so open. NICE, I think, has been particularly open to this area and has developed guides about it. I know PBAC also has some methods guides about treatment switching. What NICE says is basically that we can use adjustment methods. We just need to be careful about which ones we use, and we need to justify which one we've used. The NICE technical support documents go into quite a lot more detail. The first one was published in 2014 and explains the key methods and also gives an analysis framework, which explains how you can identify an appropriate method on a case-by-case basis. But it was recognized over time that the way these methods were being used in appraisals was still quite bad. Sometimes adjustment analyses were being accepted, sometimes they were not. And often that seemed to be because the analyses weren't reported very well or done very well. So a subsequent technical support document, TST24, was published in 2024, and it reviewed recent NICE appraisals affected by switching and found that there was often an inadequate consideration of which types of switching to adjust for, a lack of justification for chosen methods, and then the analyses that were done were often reported really badly. And so to address that, TST24 had quite a long section explaining what types of switching to adjust for, which is quite similar to the first section of my slides here, and then gives really detailed reporting guidelines. I think there's something like 6 pages of reporting guidelines. And the overall idea behind that was that hopefully if people follow these guidelines, then analyses will be done better. And then we will be able to use these analyses more regularly in technology appraisals, providing the right thing has been adjusted for. So just some final conclusions. So hopefully it's been clear from this talk that treatment switching is common in oncology trials and can have a really big impact on estimated effectiveness and cost effectiveness. Lots of HTA agencies are open to adjustment analyses, but they won't accept inadequate analyses. You need to adjust for the right things, and you need to explain which method you've used and why, and report the analysis clearly. In my experience, often adjustment analyses are frequently poorly presented and reported, and so that's going to lead to rejection. If somebody has used IPCW, and this has happened to me a few times, and you ask them in an appraisal committee meeting, which variables did you include in your weighting model, and they can't tell you because they're not the one who did the analysis, they're not sure which variables were used, you can't rely on that analysis because you don't know what they've adjusted for, whether it's been done well, and all of that stuff. So that's going to lead to rejection of these analyses. It's not a kind of plug and play type thing. And I think it's going to be really helpful if people do follow reporting guidelines, and that's going to increase the chances of analyses being accepted. The ones in the TSD 24 are really developed from some reporting guidelines that Tom Sullivan, based in Australia, and I wrote a few years ago. We've just added a few more since then. And yeah, I make some videos about all kinds of stuff to do with health economics, and there's one about treatment switching. I won't play it now, but if you go to YouTube, you can watch it, and it says most of the stuff that I've said today. Thanks very much for listening. So we've got a few minutes for questions if people would like to ask anything.
Thank you very much, Luke. It's very interesting talks. So everyone, if you have questions, please raise your hand or put it in the chat. So while waiting for everyone's question, Nick, would you mind to explain how detailed we need to get expert opinions on upweighting the survey in the IPCW weighting, like whether you need to just ask biostatistician or clinician, or you actually have to do a survey about that?
So I think there's varying levels of this and how far you can go with it. I think what is quite standard is the analyst simply goes to the clinician and explain what I would like to do. What I normally do anyway is explain concepts around confounders, maybe show some simple directed acyclic graphs, what constitutes a confounder, and then talk about the types of variables that they think might be confounders. And then we look at which of those variables might have been collected in the data to get an idea about which ones we need to include in the models. You could go an extra step of doing proper structured expert elicitation using proper methods for that. I think that's rarely been done for this particular type of thing, but I know it's starting to be done more often in HTA in general. So you could see it's starting to come in for this kind of thing, but more often it's more kind of ad hoc interviews with clinicians explaining the issues and trying to get their idea on confounders that way.
Okay, thanks, Nick. Any question from the floor? I have more question for Nick. So you mentioned about the number of observation getting very small. If there's a lot of people switch to another treatments, and that ICPW and the two-step estimate might not be able to deal with small number observation. So you know that like for machine learning method, they can deal with very rare outcomes and can be good with like different individual treatment pathway. So I would be interested in your thoughts about whether machine learning can be useful in this case, like when you have a small number of observation and a lot of people are switching.
Yeah, so some machine learning methods have been kind of developed to be integrated within these methods. So there's something called targeted maximum likelihood estimation, TMLE, which can be used with IPCW essentially to help with the model specification part. In general, with something like this, which is essentially causal inference methods, then we need to be careful with machine learning to decide on which variables to use, because often those methods are more about prediction rather than causal estimates, and they may be more likely to include variables that maybe shouldn't be there. You know, we want confounding variables, and machine learning methods may not always be able to identify which are the confounders rather than just which are variables that can improve our predictions. That said, there's a whole literature on causal machine learning now, so that is, you know, those methods are being developed. I think in terms of the small numbers and stuff like that, and small rare events, I'm not sure. I'm just not sure, because especially in the context of quite small trials, with maybe not loads and loads of different variables, I'm not sure how much you would add by trying to use a machine learning method to identify your variables. I'm sure, you know, people who know more than me about it would be able to say more, but I don't think it's really been shown in this context yet that there's a particular advantage to that.
Thanks, Nick. I'll have to check the chat if there's any question. I have a final question for Nick. Sorry, I just take some notes in here. So as a health economist, what is the boundary? As a health economist, I usually just take the hazard ratio or the survival to put in our model to do modeling. So if there's any clear-cut task between biostatistician and health economists in terms of adjusting for the treatment switching?
So yeah, I think sometimes there's a bit of a misconception that when you use an adjustment method, you're just given an adjusted hazard ratio, and often just the hazard ratio is presented for these things. And so then if you just take that, then you're restricted in the type of economic modeling you do to some extent. You know, instead of fitting independent, you can fit either independent parametric models for your survival data, or you can fit dependent models of basically using proportional hazards or assuming a constant treatment effect, which I think more and more over time is being criticized as something that, you know, that's a restrictive assumption that there's a constant treatment effect, and we may want to steer clear from that. And so that previously, I think some people thought that was a limitation of these adjustment methods, because they thought you just got a hazard ratio, an adjusted hazard ratio. But as hopefully I showed, that's not actually the case. With IPCW, you get a weighted data set. With RPS-FTM and two-stage, you get a new data set with adjusted survival times for switches. So you can still then just fit independent parametric models to each treatment arm, or you could fit a joint model. So it doesn't really restrict the type of economic modeling that you can do. It's you can still do either.
Thank you very much for that, Nick. So everyone would greatly appreciate if you could please complete a brief post webinar survey. I think that Natalia will put it on the question and answer. And also let us know about which topic you would like to learn more about in the future webinars. And the next webinar would be conducting economic evaluation alongside pediatrics clinical trial special consideration and example by Kim Diesels. It's on Wednesday, 25th of March from 11 a.m. Please register via ICTA webpage. So with that, I would like to draw the webinar to a close. Thank you so much, Nick, Natalia, and everyone for attending. Thank you.
Thank you. Cheers. Bye. Cheers.